Okay, this is chapter 3, still talking about trigger, and we talked about time trigger, which means that you have to set a respiratory rate and that will start a breath. This one talks about pressure trigger. With pressure trigger, the patient has to inhale, which means the patient has to be breathing spontaneously on their own. Now, we've talked about patients being intubated, constipated, and sedated when they're on a vent. True, but we still want them awake enough to at least take a breath. If they don't, they're going to lose all muscle strength and it will take longer to get them off of a ventilator. So we need them to breathe on their own, spontaneously is what we call it. They're going to be breathing through the ET tube, but they're going to be taking a deep enough breath that the ventilator senses the patient's taking a breath, and then the breath will start. It's just like IPPB. You guys sucked in, and when that pressure went to about -2, that pressure started. The breath started, i.e. the breath was triggered. As I was saying on the last slide, IPPB is a good example of a pressure trigger ventilator. Whenever you guys sucked into about -2, the breath was triggered. And we also say that's somewhat like NIF, negative inspiratory force. Hopefully you guys have talked about that with your PFTs. It's something that we use to check muscle function of the lungs. We just want to make sure that the patient can suck in 20 centimeters of water pressure. And if they can do that, then we say they have enough pressure to cough. -20 is nothing, absolutely nothing. It's like, that's it. So all they need is -2 to start a breath on the vent. Again, that's hardly anything at all. Okay, this one's kind of tricky. Basically, if a ventilator is too sensitive, then a patient could get a breath that they didn't even ask for. Like I said previously, the patient should have to suck in -2 centimeters of water pressure for the vent to start a breath. But if that trigger sensitivity is set too sensitive, the patient's heartbeat could even set off a breath. Just the change in the thoracic cavity could start a breath. I've seen patients who were right out of heart surgery and the vent was set too sensitive and the patient was getting 60 breaths a minute because that's how fast the heart was beating. So you have to watch the sensitivity. We want to make sure the patient's working a little bit to start a breath, and that's why we usually start with -2 centimeters of water pressure. But if that patient's not working at all to start a breath, or the machine's giving a breath before the patient's asking for it, it results in something called dysynchrony, meaning the patient's trying to exhale while the vent's trying to inhale and vice versa, and it doesn't work. And then we end up resedating our patient instead of fixing the problem on the vent. Unfortunately, that's usually what happens. Flow trigger. Flow trigger is the best. Flow trigger is the easiest. Flow trigger is what we like to use. So just remember that about flow trigger. It's the best. We like it because it's the easiest for the patient. The reason why it's the easiest for the patient is because the vent is continuously providing flow to the patient, which means the flow has gone from the vent through the circuit all the way to the ET tube, and it's right there for the patient at any given moment. With pressure trigger, the patient has to suck in through the ET tube all the way through the circuit, let the vent recognize, oh, there's -2 centimeters of water pressure being moved on my ventilator, perhaps I should start a breath, and then it goes all the way back through the circuit, through the ET tube into the patient. So as you can see, it takes a little bit of time. As fast as these ventilators are, the patient is still a little bit out of sync with the vent. But with flow, again, the flow is already right there at the ET tube, the patient just takes it in. That's the most comfortable for the patient.